Hello, everyone. My name is Mohammed Banhawi, ENT specialist and one of the admin of Egyptian ENT Forum. Today will be the second day for panel discussion, which it is otology panel discussion. So I will welcome and introduce our professors, who will be the first is our professor Ali Mahrous, who supporting our group all the time, morally and scientifically, and he will be the moderator. Nice to meet you, Dr. Ali. And I will welcome our professors, international speakers, Professor Robert. Hello, Professor Robert.
Hello, nice to be with you.
Yeah, me too. And we will welcome also for Professor Simon from UK.
Hello, thank you for the invitation.
Yeah, thank you. You are welcome. And we will welcome also for our professor, Dr. Aziz from Alexandria, Egypt. Nice to meet you, Dr. Aziz.
Hello.
And for Dr. Saad, he will join with us now. Yeah, nice to meet you, Dr. Saad. Do you hear us, Dr. Saad? Dr. Saad? I think he has trouble connection now. So we can start now, Dr. Ali.
أهلا بحضراتكم جميعا. كل سنة وحضراتكم طيبين وبصحة وسلامة. الحقيقة في البداية يعني هستأذنكم بقى نخرج شوية عن الفورمات العادي بتاع المحاضرات اللي عدت، وهنتكلم الحقيقة النهاردة يعني مضطرين نتكلم باللغة الإنجليزية طول الوقت، لأن عندنا طبعا ضيوف أجانب زي ما أنتم عارفين. ويعني أتمنى إن شاء الله يبقى بانل ديسكشن مفيد لينا كلنا. هو الحقيقة الأسئلة بتاعتكم انتم، فيعني دي أنا بس بقدم الأسئلة بتاعتكم بشكل بانل فورمات يعني. Good evening everyone. First of all, I would like to thank our panelists from abroad, namely Dr. Vincent from France, Professor Simon LIoyd from the UK. Equally important is to thank our national panelists, namely Professor Aziz and Professor Saad Zayed. Robert Vincent is an otologic surgeon from France. He joined Cosey Clinic in 1991, and he has performed more than 7,300 operations for otosclerosis and more than 4,000 ossicular reconstruction surgeries and more than 260 operations for congenital malformation of the ossicular chain. This is a humongous number of surgical cases which reflect a vast experience in the field of otology. Not only that, but Robert is actually a general secretary and co-founder of LIoyd, and all of us in Egypt know LIoyd. LIoyd is basically the Life International Otolaryngology Network, which is actually based in Europe, but is being watched everywhere in the world. And it's actually a live, free of charge, very educational surgical website. And I will take this opportunity to actually invite you on behalf of Dr. Vincent to attend the LIoyd network on the 18th and 19th of May this year. And I would ask you kindly to pre-register beforehand on the website that you all know of. Robert is also the editorial board of many international respectable journals. So welcome, Robert. Simon LIoyd. Simon is actually a professor of otology and skull-base surgery in Manchester Royal Infirmary. Simon is not just trained in the UK, he's been actually trained in the UK, in the USA, and in Copenhagen as well. He was awarded the Dalby Prize in 2017 by the Royal Society of Medicine as the greatest contributor to the otology research in the UK in the last 5 years. And he's the first UK surgeon to introduce gentamicin prehab to patients undergoing vestibular schwannoma surgery. Simon is the secretary of the British Society of Skull Base and Otology Society as well, and many, many more. Professor Aziz Belal is well known in Egypt, in the region, and actually in the world. Aziz is a professor of otology in one of the deeply rooted medical schools in Egypt, Alexandria. And he's the ex-dean, actually the youngest dean in his time in Alexandria Medical School. Aziz has spent several years as a fellow of Chocolate in the USA in the, I take it in the 70s or thereabout. And he's actually, this has added a lot to the depth of understanding of the otology, particularly the pathology of the temporal bone. Last but not least, we have Dr. Saad Al-Zayat from Kafr al-Sheikh. He's the chairman of ORL department there, and he spent a few years in France. So, can you hear me? Sorry for this technical issue. So, ladies and gentlemen, we have the top-notch panelists tonight, and let us hope that this would be reflected on the benefit that you're going to get at the end of our panel discussion. And before we embark on the panel discussion, I would like to make a few points. The first point is meant for the respectable panelists, essentially to state that this platform, which is the Egyptian ENT network, is founded by the junior and middle grade doctors in Egypt. And it is meant to exchange experience in the field of ORL. And the direct, the classic example, if any of the doctors confront a difficult clinical scenario, they would actually present it on this platform to get the direct experience of their seniors. Therefore, I would urgently ask you as panelists to keep it as basic as possible, but to keep it precise, concise, and to the point. The last point I'd like to make is to make a disclaimer that this platform that we are all talking from is actually neither governmental nor profitable platform. So there are no conflicting interests or any financial issues to be disclosed. Now, we're going to go for the panel discussion that is actually titled Current Thinking of Tympanoplasty. And as you all know, that tympanoplasty is a reconstructive surgery of the tympanic membrane and or the ossicles with or without mastectomy. So if we think that tympanoplasty is just to repair the drum head, then we have lost the plot. Whenever we have a perforation of the tympanic membrane, we need to just to think beyond the tympanic membrane, which is to think of the middle ear cleft, including the ossicles, as well as the mastoid as well. So the primary classification of tympanoplasty is the actually Wullstein classification, which has been there around for more than 60 years. Now, the question is to Dr. Robert Vincent. Do you know of any, or actually, are there any pros and cons for this classification, Robert?
I'm not sure I understood your question about this classification because I don't use it myself. I
So
mainly
the
use.
classification, basically, as you can see it on the screen, it's a type 1 tympanoplasty.
Yeah, I don't see the picture on the screen. But
So can we make it visible, Muhammad?
Okay, yeah, that's fine then. All right.
Can you see it now?
Yeah. Well, I'm not using this classification. I use the, but it's mainly for ossicular reconstruction. I use the Wullstein cartouche classification, but I mean, this one is of course very well known. So I don't say, I cannot say many words about that because I'm not really using it. In my opinion, this is a little bit too small in terms of groups. There are a lot of missing other groups, and including in the Wullstein cartouche classification, some of them is still missing. We still miss the fact, for example, that we are a stapes fixed plus absence of malus, something like that. So that's a very important point, I think.
Right. So essentially, you don't use it because it's not clinically applicable. Is that what you mean? Or
no, it is clinically applicable, but it's to me, it's not enough to have only 4 groups, because there are much more different situations than only these 3. I won't say about a type 1, which is only laryngoplasty, but the other one, type 2, 3, and 4, are related to the status of the ossicular chain. And I think we have much more different types of situation which needs to be classified. And with the Wullstein cartouche, they are a little bit more than this. It's not perfect, but it's a little bit better than this one. According to me, of course, that's only my position.
Is Wullstein cartouche classification differentiated between type 1 tympanoplasty and laryngoplasty? Because this is a question for one of the target audience, actually. So do you distinguish between the two, Robert?
No, in fact, in Wullstein cartouche, it's mainly for ossicular chain issues, ossicular chain problem. It doesn't talk about laryngoplasty. So it's group A, B, C, D, E, and F, and each group corresponds to a different situation. For example, group A is presence of malus and stapes. Group B is presence of malus and absence of stapes superstructure with the mobile foot plate. Group C is a mobile stapes with absence of malus. Group D is absence of malus and stapes, and then group F, for example, is stapes fixation, which is a little bit better than the only 3 groups, but it's not perfect at all. It's still missing some other things.
Great. So Simon, do you use this classification in the UK or the Wullstein cartouche as well?
No, we use the terms type 1 quite frequently, and we use the term type 3 quite frequently. But the other types we don't really use, and I think that any classification system really needs to have a clinical application, and I think that classification system was designed in 1956 when our practices were very different, and the surgical options that are available now for patients with ossicular injuries is much different compared to how it was in 1956. And I don't think most of those types within that classification really relate very well to current otological practice.
Right. So would you make any distinction in the UK between laryngoplasty and type 1 tympanoplasty?
No, broadly speaking, they're the same.
Right. Okay. So that's the answer to a question from Osama Bisar. So now, this question I would like to actually direct it to Simon LIoyd. You know, Simon, whenever we see patients with this, if you have a patient coming to you with this audiogram of bilateral conductive hearing loss, can you see it on the screen on the right side?
I can see it now. Yeah.
And another patient, the screen on the left side, which is actually unilateral conductive hearing loss.
Okay. It's quite small actually, but I can yeah, that's
right. Well, essentially one side is perfectly normal hearing and the other side is a conductive hearing loss.
Okay.
Now, when you try to counsel these two different patients, one with bilateral conductive hearing loss, almost symmetrical on both sides, and the other with normal hearing on one side with a maximum conductive hearing loss on the other side. Now, would you actually apply the Glasgow benefit plot anymore, or use the Belfast rule of thumb to counsel these patients?
Sort of. I don't really use the Glasgow benefit plot. I can't really see a strong reason to use that in individual cases, but I think when you're publishing results and looking at changes in results within groups, then the Glasgow benefit plot can be quite helpful, because you can see how people change from one group to another. The Glasgow, Belfast rule of thumb, I do think that actually is quite helpful. So what you need to try and aim for is to bring the hearing in the ear that you're operating on to within 15 decibels of the other ear if they're going to get significant benefit from it. And I think that does still stand in clinical practice today. And I counsel patients, if we're not able to get, or are unable or unlikely to get close to that, then I counsel them against an ossiculoplasty. The only caveat to that, I would say, is that you can sometimes bring patients within aidable hearing levels by improving their conductive hearing loss, even in the presence of a significant sensory neural hearing loss. So there are certain circumstances where you might not stick to the Belfast rule of thumb, but broadly speaking, I tend to.
Yeah, but if you've been given the opportunity to actually operate in either of these patients, which one would you probably not guarantee, but you give them a better chance to improve their hearing? Would you choose the patient with the audiogram on the right-hand side, or would you choose the patient on the left-hand side?
It depends on the circumstances and what the cause of the conductive hearing loss is.
Right.
So if you've got a unilateral otosclerosis, then that
no,
patient.
we're talking about a central perforation here, actually, bilateral mucosal type chronic otitis media, the central perforation, dry central perforation.
For the one on the left?
Both of them.
Both of them. Okay.
Yeah.
I mean, again, it depends on the status of the ossicular chain. So, if you've got a stay-piece superstructure present, then the chances of successfully improving the hearing to within 10 or 15 decibels of the other ear are much higher than they would be if the stay-piece superstructure is absent.
Right.
So I'd have to assess that at the time of the surgery.
Great. So it all depends on the status of the ossicular chain and what have you, yeah?
Absolutely.
Great. So this question is for our great Professor Aziz Belal. You've seen this patient, Professor Belal, in your clinic, coming to you with this kind of subtotal perforation, almost invisible anterior rim of the tympanic membrane, with the other side having perfectly normal hearing. How would you counsel them in your clinic, Prof. Belal, and how would you deal with this kind of no rim anteriorly?
Can I go back to the question you asked to Simon about the difference between myringoplasty and tympanoplasty 1? Because there is a difference. The difference is whether you do an exploratory tympanotomy, whether you turn a flap or you don't turn a flap. So if you don't turn a flap, like in fat myringoplasty, if you're doing overlay myringoplasty, you don't explore the middle ear, and this is when you call it myringoplasty. Right. If you turn a flap and explore the middle ear for the ossicles, then you call it tympanoplasty 1. And right. I think this is a critical difference in the technique. Right. About the subtotal perforation, with the anterior rim is almost gone. You create an anterior rim, so I always use a piece of cartilage anteriorly under the graft to support my facial graft or perichondrium graft anteriorly, and try to elevate a little bit the the skin of the anterior wall and put the graft a little bit under the skin there. So you can create an anterior, there is a post-operative blunting in those cases, but this is usually the technique we use to avoid that the underlay graft would fall into the middle ear.
So essentially, you're going to use both a cartilage and fascia, a temporalis fascia, actually two
perichondrium with cartilage.
Right, and you do it in an underlay technique.
Always underlay.
So you don't use a kind of overlay technique in these patients, because overlay technique is well known that you would avoid blunting. Is that something that you would contemplate? With
the overlay technique?
The overlay technique, one of the inherent advantage of the overlay is that basically, because you're not going to disturbing the annulus, then there would be no blunting at all. Would you? You don't really. You're not fan of it.
I think this is the reverse of what we've seen, and even temporal bone post-operatively, where overlay technique almost causes in everything in either lateralization or blunting of the anterior angle. And this is one of the disadvantages of overlay. I thought that this is why we stopped doing overlays.
Right. So the question to Professor Saad Zayat here is that, Saad, would you request a CT scan for mucosal chronic otitis media? You have a patient with a dry central perforation, or actually with a central perforation. Would you request a scan for these patients? Saad, can you hear us? Dr. Saad? It seems that there are technical issues with Saad there. So can I divert this question to Robert? Robert, can you hear me?
Yes, I can hear you.
Right.
Usually we don't ask for a CT scan, and I just come back for the what Aziz said. I fully agree. I do overlay technique because there's no perfect technique, and whatever you do, there's always a problem. With underlay technique, the risk is to have the graft falling down, and with overlay technique, the risk is blunting or lateralization of the tympanic membrane. So it's clear. We have some techniques to decrease that, to decrease the risk. I always put the graft over the bony canal wall and over the malleus handle. And at the end of surgery, I will plug completely the anterior angle and also the full canal with gel foam to try to keep the graft down into the ear canal and to try to preserve, to reconstruct the anterior annulus, but it's not so easy. But usually, to answer to your question, if I have a regular tympanic membrane perforation, if there is no issue about risk of cholesteatoma, I usually do not ask for a CT scan, except if we have a really bad mucosa. Of course, I would ask for a CT scan in that case, but only in this case.
So if you have a patient with a central perforation, but the ear is persistently discharging, then you may request a scan. Is that?
It depends. So, it's always difficult to answer to that. It depends. It's a really case-by-case discussion. If you have a clear vision of the middle ear to the tympanic membrane perforation, there is no, in my opinion, there's no indication for CT scan. But it really depends. If you are not sure, if you have a...
Yeah, as you know, there's a school of thought which essentially, if you have a central perforation and the ear is persistently discharging, there is a thinking that there may be a reservoir in the mastoid, and in this situation, if you do a CT scan, that may show you the status of the mastoid bone, and you may actually, it may entice you to perform some sort of cortical mastoidectomy with the tympanoplasty. So you disagree with this school of thought, is it?
Yeah, I don't say I disagree. I say I don't do that. But that's a different way of approaching this case.
Right.
We have cases like this where we have a really huge chronic discharging ear. We try to treat it before doing any surgery, and we cannot stop the discharge. And sometimes we have to do surgery, and we can stop the discharge by chance if we can close the tympanic membrane. So it's very interesting to see that.
Do you have the same experience, Simon?
Yeah, it's pretty unusual to do a cortical mastoidectomy in a patient with a chronically discharging ear when there's only mucosal disease.
Right.
The tympanoplasty techniques are very reliable, even in the presence of infection. So there's very few cases where I think it's necessary to do that.
Ali, can I comment on this?
Please go ahead.
A few years ago, we had a PhD thesis done in Alexandria where we compared 50 patients with discharge when we did cortical mastoids, and the other 50 we did not do cortical mastoids, and the closure rate was almost identical. So
Right.
we think cortical mastoid as a regular surgery is not really indicated.
So that's great. So there is agreement between the Egyptian experience and the Europe experience, which is good. Now, if I take you to the next question there, that question would be for Robert Vincent, if you don't mind, Robert, to answer it. Essentially, you've performed stapedotomy on this patient, not you, but someone else has, and it ended up with a perforation after surgery. Not only that, but actually the audiometry has shown the maximal conductive hearing loss. So you, as a surgeon, you actually think that probably the surgery wasn't successful, the stapedotomy wasn't successful. Now,
Looks like.
well, the scenario is you've got a perforation, you're gonna explore the middle ear and check the situation of your prosthesis. But would you revise the stapes and you do tympanoplasty at the same time, or would you actually do tympanoplasty and once you make sure that the perforated tympanic membrane has healed up well, then you go in and do your stapes procedure?
Yes, I would do that in 2 stages. I would do the graft first, tympanic membrane grafting first, and then wait 6 months at least to be sure about the stability, and then I would do the stapedotomy between 6 months and 1 year.
So
that's the kind of rule.
So do you apply this principle for ossicular reconstruction?
No, I just apply that only for stapes fixation. That's all.
What is the difference between?
Well, that's an interesting question, because I think it's a stupid decision, because I don't think there's a great risk to do it. But it's a kind of medical legal issue. If we have a complication following that kind of patient, and if you do a stapedotomy with simultaneous tympanic membrane perforation, there's a risk that you can have the patient will sue you, and then you're going to lose because you've done this. And in any books, you can see that it's mandatory to do that in 2 stages. But I do believe, if you ask me personally, I do believe that it would be possible to do it in 1 stage for sure. But I always do in 2 stages.
But the same patient would sue you if you reconstruct the ossicles at the same time you repair.
Yes, but it's not regarded as a contraindication to perform stapedotomy with a perforated eardrum. It's in France. It's a kind of contraindication. You really need to have a closed tympanic membrane before doing stapedotomy.
So that is kind of like an agreement in France.
I wouldn't say agreement. We not agree about that, but that's. I mean, it's a rule. Yes.
So is it the same experience, Simon, in the UK? Is it?
Yes, we would certainly do that in 2 stages. I think Robert's quite right. I think it would almost certainly work out fine if you repaired the drum at the same time, but there's a little bit more to lose if you get infection or other complications, and it would just give you the reassurance to have that drum healed before you proceeded with the stapedectomy.
So likewise, if you do ossicular reconstruction with a perforated tympanic membrane, you do them simultaneously with no issue in the UK?
Yeah.
Right. Prof. Belal, do you have similar opinion?
So you see, British and French, they do agree.
Well,
occasionally.
I think I think what you should do is depends on the timing that you see this perforation. Usually the tear is not like what you have shown us. The tear happens in the tympanomeatal flap posteriorly, usually, where you have turned your flap and it has teared from you. So if you're at the time of the surgery, you repair it immediately with a graft or whatever. If you see it in the post,
Prof. Belal, I'm talking actually, as you can see, the perforation, it has healed up. The perforation is it's kind of like an old perforation. It's not immediately. Obviously, if you were at the time of surgery, you would repair it at the same time. But I'm asking actually if it happened later on. Kind of
depends on when later on, because sometimes we see this kind of perforation posteriorly, and we see it in the first 2 weeks or 3 weeks, and I think this might be indicated for fat myringoplasty, that you would do it for this patient. But otherwise, if you see this patient few months or a year with a big perforation like we've seen in your slide, then there is no way to do it except staging, of course.
No, but mind you, Prof. Belal, what I'm actually saying that this patient comes to you with a maximal conductive hearing loss, and someone has operated on him a kind of stapes surgery. So you're going to explore this ear anyway. So you have a perforation, but also you have the maximum. You stage it.
Of course.
So you're going to stay. Okay, so this is agreement between Egypt and Europe as well. Great. So now the next question is, that question would be for Prof. Belal. You've got, I'm not sure whether you can see this well or not. This is essentially automycosis with a central perforation of the tympanic membrane. We see this sometimes, and if you clean the ear, you cannot really give ear drops because they really burn like a hell for these patients, and they may damage the middle ear mucosa as well. So how would you manage them? This is a question by one of the target audience in the Facebook group. How would you manage this condition, Prof. Belal?
Repeated suction, Castellani paint that you use creams, antifungal creams. You don't have to use antifungal drops because if they fall into the middle ear, they'll cause a lot of pain. But I think frequent ear toilet under the microscope with suction and painting and putting some antifungal cream, and then obviously you have to go and close this perforation because persistent perforation, the fungus never will always come back.
Right. So any different experience from Robert or Simon?
I would do the same. I would use antifungus treatment, and usually it works well. But it needs to be, in my experience, quite a long-term treatment for a few weeks to be sure that's going to work.
And the microsuction is particularly important in these cases. I think you have to keep removing the hyphae, and the antifungal treatment will eventually settle it down.
Great.
Do you use Castellani paint, Simon, in Britain, in the UK?
We tend to use something called triad cortil or otacome. It's got triamcinolone and an antifungal agent as well. So it's kind of like a domestos for the ear, but it works very, very well.
Yeah.
Well, Castellani paint is really very much used in Italy. I'm sure of this. Now we come to this question from one of the target audience as well. The question is about the permeatal approach and using tragal cartilage graft through the perforation without elevating the tympanomeatal flap via endoscopy. Is anyone has experience in this kind of thing?
Yes, occasionally. If you have a relatively small perforation and it's not marginal, I use a sort of butterfly graft, which is just a small cartilage graft with a a cut around the rim. So you've got two butterflies, one that goes medial to the tympanic membrane and one that goes lateral.
Right.
But there's only a very specific type of perforation that I use that for. If the perforation is too big, it never sits very well and it tends to medialize. And if it's marginal, you just can't get it to the leaves to sit very well either.
Great.
You
now,
can use fat also, Ali, for this kind of perforation if it is less than 2 millimeter. But again, I have to warn you against the rim of the perforation with the squamous epithelium might be migrating into the middle ear. And in those cases, if the squamous epithelium, you did not freshen up well the edges, then you'll develop a cholesteatoma secondary to your myringoplasty.
That's a good point. That's really good point. So actually, if you have a small perforation and you refreshen it quite, probably I would say quite generously, then you may end up converting it into a medium-sized perforation. And in this situation, fat graft doesn't work, is it?
True.
I think that you're getting at this point, Prof. Belal, yeah?
No, okay. I think you have to introduce your endoscope through the perforation and see if you use a 70-degree endoscope, then you can see the squamous epithelium, whether it's creeping into the middle ear or not. The undersurface, I mean.
That is going to be a bit technical, but anyway. So now there's the same question I was actually asking the respectable panelists. Would you prefer tragal or conchal cartilage? That is if you're performing the retroauricular approach or post-auricular approach. You have got both cartilages available. Would you prefer tragal or conchal cartilage in tympanoplasty in general? I think that question would be for Robert Vincent, if that okay.
As I do always transcanal approach in all my cases, I always try to take the tragal cartilage perichondrium first, and if I don't have any more tragal perichondrium, then I go to the concha. But usually I try the tragal one first.
Yeah, but the question is actually if you were already gonna perform a post-auricular approach.
No, I never do. I never do it. So really, I never had to do it. But usually, let me answer with my colleagues in the clinic who are doing this. They sometimes do posterior approach and they use fascia because of the posterior incision, of course.
Fascia, you're going to use fascia.
Yeah.
Okay.
Yeah.
So any preference, Prof. Belal or Prof. Simon or Prof. LIoyd about this?
Simon?
I mean, as to the nature of the tragal cartilage versus the conchal cartilage.
Yeah, so almost always I use a permeatal approach, but if it's a very large perforation, I sometimes do use a post-oral approach. In terms of all my tympanoplasties with cartilage and perichondrium, other than the odd exception like the butterfly graft, and I use the perichondrium still attached to the cartilage. And in terms of the quality of the cartilage for doing tympanoplasty, I find the tragal cartilage is often a little thicker, it's a little bit pitted, and elevating the perichondrium around the margin to give yourself a perichondrial rim is often a bit more difficult because there's sometimes adhesions where there's little breaks in the cartilage. So in terms of a material, I prefer conchal or actually triangular fossa or concha cymbi cartilage, but I don't use that very often. I usually end up using the tragal cartilage just because I'm doing a permeatal approach most of the time.
Yeah, if you allow the moderator to state his opinion, I actually agree with this. Actually, I found the concha cartilage is actually more pliable to kind of insinuate it to where you want it to be, but obviously that is my opinion. So I
contradict you in this, Ali. I find that the tragal cartilage is much better to conform with the middle ear because the conchal cartilage has a curvature
So you can
it's
score
much more difficult to use.
You can
And
score it,
tragal cartilage is there, and you use the perichondrium as a graft. And like Robert has said, 90% of my cases are transcanal, so it's there. So why go to the concha?
Yeah, no. If you were to perform transcanal, I think it would be wise to use the tragal cartilage and perichondrium, obviously. But if you're doing retroauricular and you already opened up the plane and it's actually closer to you, and you're not going to make any incision if you're doing post-auricular approach to harvest the conchal cartilage. But you're going to do a new incision for the tragal cartilage if you already opened the post-auricular area. So anyway, I can see
just one point. I just want to say that I mostly do not use cartilage. I always use perichondrium. So that's the main reason why I'm taking also the perichondrium from the traders.
I think, Robert, we will come to this very debatable point later on in the panel discussion, because it's a very important point actually. And I think so many questions about the cartilage versus the fascia coming from the audience in this group. So I see Saad comes in and goes out. So now, does any one of the respective panelists do end-oral approach in tympanoplasty anymore?
Not myself.
And the oral approach, I use it. I use the vertical part, but do not go out in the like I do the vertical part inside the canal in small canals to get it a little bit bigger, to fit my self-retaining speculum. And this is a very important point, that you have to have a good self-retaining speculum to do the transcanal surgeries, and you have to be very comfortable with it. I have one that I'll tell you about. This is a Spanish self-retaining retractor that Jose Prades, maybe Robert knows about him. He was in Barcelona. And I bought this self-retaining transcanal retractor maybe almost 40 years ago, and I still do surgeries with it. I've done thousands of cases, and it's still holding with me. So you have to be comfortable with your retractor. And
that's, I think, a major point. That's a major point, to have a speculum holder. That's absolutely important.
What kind of speculum holder are you using, Robert?
I'm using this made, it's made by it was in a clinic before I came, so you must say it's a long one. It's a long-term one now. It made in two parts, 3 parts, by the way. One, there is a plate underneath the head of a patient, and then you have 2 other parts which are connected to this plate, and they are 2 joints, so you can angulate, you can angle the speculum to fix this, to stabilize the speculum, which I think is really nice.
Right,
Simon.
So
you're using a different one?
Yeah, I actually don't use a retractor as such when I'm doing permeatal surgery. I put the speculum in and then put a sticky film, Tegaderm or Opsite, whichever one you want to use, over the speculum, and then I cut a cruciate cut in it and fold the limbs down into the speculum, and that supports it. And you can still move the speculum around a bit just to get a different view if you need to, and that avoids the need to have a self-retaining retractor.
Right, great. So now this is a very common question by the audience about the underlay versus the overlay, and we all know that this is in relation to the tympanic annulus, over and under. Now probably the question is, what is the percentage, rough estimate of the number of cases that you've done underlay versus overlay, Robert?
No, I always use over and not over under. So it's a pure overlay technique. I put the graft from one side of the ear canal to the other side and over the malleus handle. Okay.
So I think there's a differentiation there to be had. I think that the picture showed an overlay, and it showed an overlay underlay.
Yeah.
But but that's different from an underlay.
Sure.
Yeah.
So
No,
just
well, probably the picture is not actually the real question. I agree with you, Simon. The question is overlay versus underlay.
So it's overlay.
Robert is saying that actually most of his cases, or all his cases, is actually overlay.
Yes.
Yeah? But then the question to Robert, how would you test the oscillatory chain then?
But there's not a problem with that. I elevate the flap, and then you go into the middle ear, and then you can check the oscillatory chain. I don't see any issue with that.
So that is not actually overlay.
Yeah, but for me, overlay is placing the graft over the malleus handle and over the bony canal. That's a question of definition in turn.
No, but that's not actually the conventional definition of overlay, because my understanding actually I mean, I'm not sure whether Prof. Belal or Simon agree or disagree with me. Actually, overlay for me is actually in relation to the annulus. Essentially, you're gonna go in, you lift the tympanoid flap, but you remain superficial or lateral to the annulus,
I understand.
and then you plug your graft in.
That's not the way I'm using it. So of course it's underlay in that case, but putting the graft over the bony canal wall.
And I think Prof. Belal has answered this. He doesn't do any overlay by the understanding of mine. Yeah, Simon, do you do?
Yeah, the overlay, the true overlay technique that you're describing is where you enter the gap between the outer layer and the fibrous layer of the drum, and you remove the outer epithelial layer.
That's right.
That's a technique that I don't know that anybody uses in the UK. I have seen it used in the States, but it's not something that we use for the reasons that Dr. Aziz mentioned. You can have implantation cholesteatomas, and you often get some blunting of the anterior margin with the onlay technique. I do like the underlay overlay technique, which is basically which I think is what is what Robert's talking about. So you lift the malleus off the drum, or the drum off the malleus, and you put your graft on the malleus but underneath the drum, and that's a fantastic technique. It really gives great support.
That's the one I'm using. That's the one I'm
using. And it really addresses the difficult area, which is the superior anterior part of the drum, which is where grafts usually fail, if they're going to fail, because you just can't get adequate support.
But there's still a risk of blunting and lateralization. That's the negative points of this technique, but each of them has a negative point.
Now, this question is for Prof. Belal. You've got a patient who's a 35-year-old man who comes to your clinic with the audiometry showing 40 decibel conductive hearing loss on this side, Prof. Belal. So you've seen a perforation now, and this is the right ear of this patient. But you see a myringosclerotic patch, which is quite a big one. It's almost involving the posterior part of pars tensa. Now, the question, actually, this is a question posed by the audience. Would you remove the myringosclerotic patch or plaque, or leave it at the time of tympanoplasty?
There are two types of tympanosclerosis, as you know. Myringosclerosis, like the one you're showing.
This is what I meant.
And then ossicular tympanosclerosis. So in this case, you have to definitely explore the ossicles for the mobility
because this is a subsequent question actually about the tympanosclerosis.
Okay.
This question about myringosclerosis.
Myringosclerosis, you remove if the tympanosclerotic patch is big enough or very big, or it is hindering the movement of the handle of the malleus, like in this case, or it is touching in front with the canal wall, so it is hindering the movement of the tympanic membrane. So these are the indications for removing the tympanosclerotic patches in the eardrum. If they are big enough, hindering the movement of the tympanic membrane anteriorly, or hindering the movement of the handle of the malleus. So in this particular case, I would dissect the tympanosclerotic patch from the handle of the malleus, remove it and to go ahead with the technique that Robert and Simon are doing, putting the grafts over the handle of the malleus and under the tympanic membrane.
Right. So the same experience, Robert and Simon?
I would probably remove the plaque, but it really depends on, of course, the problem of, as you said, fixation of the malleus handle or not, and also the thickness of this plaque. Because sometimes it doesn't fix the malleus, but it's too thick to keep it in place, because then it's a problem to place the graft underneath. So in many cases, we have to remove that, in my experience.
So now the same, Simon, yeah?
Yeah, I think you need healthy tissue for the graft or for the epithelialization of the graft post-operatively, and I think I'd rather deal with a larger perforation with healthy epithelium than try and get that to heal as it stands.
So
you never know about the risk of epidermal ingraft also underneath the plaque like this, so it's important to remove it, I think.
That's right. That's right. I think that's an important point as well. Now, if you have a tympanosclerotic plaque that is tethering the ossicular chain, how would you deal with it, Robert?
You mean a plaque, a tympanosclerosis fixing the ossicular chain?
Yes.
Is that? Yeah. In that case, I will dissect, of course, it depends what you have. It could be a lot of different things, because usually when you have tympanosclerosis, you do not have only one single thing. It is very common to have simultaneous eroded incus, for example, and stapes fixation or malleus fixation plus eroded incus or things like this. But I do not stage unless it's not a stapes fixation. If it's a stapes fixation, then I do the stapedotomy 6 months or 1 year later. On the other cases, if we have just...
Robert, excuse me, Robert, yeah. I seem to have lost you here. So if you have a plaque that is fixing the ossicles,
yes,
would you leave it or would you remove it?
No, I remove it.
So if you remove it, don't you risk kind of misplacing the stapes, for example? Because sometimes it's like a concrete is actually fixing everything. Yes.
No, it's a different story. If you have a stapes fixation, then I don't touch the stapes unless I have a fixed closed tympanic membrane. So in that case, I would stage. I would do the graft and then leave the stapes fixed like that and do the second stage. But if there is a plaque which is going into the middle ear and, for example, fixing the incus or the malleus with a mobile stapes, then of course I will dissect the plaque of tympanosclerosis and put a prosthesis on the same stage, removing the incus, for example. It really depends on the situation.
So,
Ali, can I make a comment on the stapedial tympanosclerosis? Because
yeah, go ahead, please.
Sometimes you have a kind of tympanosclerosis which is soft. It's like an onion, and you can dissect the tympanosclerotic plaque of the stapes foot plate and mobilize the foot plate doing this. Sometimes it is hard, you cannot do that, then you have to stage. But sometimes there is soft tympanosclerosis and there is a hard tympanosclerosis, and you can differentiate between the two.
Yeah.
Well, my question is about the hard tympanosclerosis that is actually amalgamated with the ossicles. And if you try to remove it, you may risk kind of, ossicular disruption, including...
Ali, in that case, what I would do, let's say each of us with the technique that we would use. I would separate the incus from the stapes first and try to dissect the tympanosclerotic plaque. If it works fine, and if I have a mobile stapes, then I will do the ossiculoplasty on the same stage. But I will always try to remove the tympanosclerosis during the first operation, of course.
So, well, okay. How about, Robert, sorry, I mean, it's a really endless question.
Yeah, let's keep going.
How about if this actually happened with me? The plaque is very tough and encircling the ossicles, including the malleus, incus, and the stapes. And now you try to remove the incus amongst this mess of everything is amalgamated together. Now, is there a risk for the stapes dislocation? And
Of course.
would you be probably safer to actually stop doing this procedure and give the patient a hearing aid?
Yeah, but I mean, there's always a risk when you do some kind of surgery, and of course the decision will be made peroperatively. But it's in my experience, it was very rare that I had to stop surgery for tympanosclerosis. Usually, you can really remove the plaque safely, separating the from the stapes. But of course, it depends on the situation. But in my experience, it's very rare.
Right, Simon, the UK experience in this?
So I agree with Robert. Most of the time, you can remove the tympanosclerosis, and it is softer, and you can definitely tell the difference between the bony tissue of the stapes and the tympanosclerosis. But there's a risk balance ratio with all surgery, and I think with experience you learn the point at which the risk becomes too much, and you are always able to resort to a hearing aid or an implantable bone conduction hearing aid if that's the situation you find yourself in. So I think there is no point putting the patient at too much risk. How you define too much risk is difficult, and it will depend on the surgeon, depend on their experience and their level of skill as well.
It's a case by case discussion again.
Absolutely.
Had you seen the Egyptian tough tympanosclerosis patches? You'd probably change your opinion.
I've seen that, Ali, because you remember I went to Egypt to do some kind of surgery, so I remember some kind of thing like that.
Dr. Ali, sorry, I have some internet and technical problem, and now I with you.
انت رحت نمت وجيت يا سعد بلاش بقى.
No, I now I with you.
So, had a nap and then came back to us. Anyway,
okay.
So, we go for the next question is about this patient. I think I'd like to ask Simon about this. This is a 7-year-old boy or girl coming to you with conductive hearing loss of 35 decibel on both sides. You can see now, Simon. Is it clear now on the screen, or shall I make it a bit clearer now?
Get it bigger.
Can you see it now?
Yeah.
Yeah. So essentially, as you can see, the tympanic membrane almost wrapped on the medial wall of the middle ear structures, and that is on both sides.
Yeah.
This child came to you with a conductive hearing loss of 35 decibel on both sides, and you're gonna give these, the parents the option, or these options: watchful waiting, hearing aid, long-term ventilation tube insertion with adenoidectomy, cartilage tympanoplasty, with or without silastic, or balloon tuboplasty.
Okay.
Which one would you go for, Simon?
So, I mean, that's a pretty established ear with very poor eustachian tube function, and I don't think watchful waiting is going to change the situation, but you could watch it and see whether the retraction gets worse, and you could potentially offer them a hearing aid, but that wouldn't be my number one choice. I think my number one choice initially would be a standard grommet, just to see how they respond to that before you proceed with a longer term grommet. And I wouldn't necessarily do an adenoidectomy initially, but I would certainly want to assess the nose and see whether there's any disease there that needs dealing with. And if the adenoids are particularly large, or there's chronic rhinosinusitis or other pathology, then I would deal with that. I think a cartilage tympanoplasty, that might give you some strength to the drum, but there is a risk when the eustachian tube dysfunction is ongoing that you might get retraction around the edge of the cartilage graft, and it wouldn't address the hearing. So I wouldn't necessarily use that as an option, certainly early on. In terms of balloon tuboplasty, I use that pretty regularly in adults. I have to say that the benefits are very variable, and I would certainly not say that it's a panacea for curing pure eustachian tube function. But I don't really have any experience of using it in young children, so I probably wouldn't use it in this case. So in summary, I'd probably just use a normal grommet initially and see how they go, and then assess the situation over the coming months.
Great. Any different opinion from this by the panelists?
Can I add something?
Yeah.
I think this case of atelectatic eardrum, it doesn't have to do anything with adenoidectomy. I think this is an allergic child that has to be treated very well for allergy. I would put a T-tube and wait for him to be 12 or something, then start thinking of cartilage tympanoplasty when he gets older, because atelectatic eardrums, once the T-tubes come out, then he'll get back his conductive hearing loss.
Right. So how would this be actually? I mean, this is a question by the audience about preventative tympanoplasty with normal hearing. Has any one of you had experience with this? Robert, that's a question for Robert.
What do you mean exactly? Preventive tympanoplasty. Yeah. I would follow the same rule as Simon. I would probably put a tube in this case and wait and see what's going on. We have to do something because we have 35 dB hearing loss. So with young child, so we have to improve his hearing. Yeah, but I don't do tympanoplasty in this case.
So you don't do any preventative tympanoplasty?
No,
yet.
No.
Okay. Oh. Now, this question is for Professor Saad Zayat. Saad, can you hear us?
Yes, yes, I hear you.
You've got this patient who's actually 55 with conductive hearing loss of 35 decibel on both sides. And that's a 55-year-old gentleman. Is your choice would be the same like the previous one, the kid, which is probably there is agreement about ventilation tube, or would you deal with it differently? And this
I think in this age I will differ from a child. I think in this stage I will make full investigation like CT to see the mastoid cavity, what about it, and I see tympanosclerosis patches. I think in this case, I will explore the middle ear, and I will make tympanoplasty, cartilage tympanoplasty in this case.
Fantastic. Any different opinion from the tympanoplasty for this 55-year-old man with bilateral conductive hearing loss?
I would do surgery. The problem here is the retraction that you can see in the attic area. We need to rule out any cholesteatoma. This is in that case I would ask for a CT scan. But I would do for tympanoplasty. But the only thing I would add is that, as you can see, there is an incus erosion in this case. So we have to do ossicoplasty at the same stage. For sure.
Simon?
Yeah, I mean, the middle ear, it probably is ventilated anteriorly. It's obviously difficult to be sure, but I think a tympanoplasty would probably give you a relatively well aerated middle ear, and an ossiculoplasty should work quite well. The head of the stapes is present. It's likely that the crura are intact, and a partial ossicular replacement prosthesis should work pretty well in that situation. I agree with Robert. I think there is some attic erosion. You just need to look at that very carefully under the microscope and make sure that there's no keratin accumulating. And
there's no history of ear discharge or anything, and you can see the fundus of it. And this is a 55-year-old man. Actually, to be controversial here, I probably give the patient the choice. And I think the choice of having a hearing aid is not a bad choice here. If I may express my opinion, as long as I'm going to follow up this patient, and I know that this patient is quite handy to be seen later on. I'm not sure whether Prof. Belal agree with this or disagree with it.
I think you are turning into an audiologist, Dr. Ali.
Actually, Simon would agree with me about this.
Well, in the UK, we would counsel them about all the options, and
Yes,
as I'm sure everybody would, and it would be his decision at the end of the day.
yeah, that's right. So I think.
But Simon, you always, as a surgeon, you give him surgery as a first choice, right?
Well, I love doing the surgery, but I have to be honest with the patients and tell them everything.
Yeah.
I think the option of hearing aid is there. But anyway, I think we have discussed this before, so we're gonna skip it. Now, this question is, for Prof. Belal. You've got this patient comes to you with a dry central perforation, but this is the only hearing ear. The other ear, the other ear is too profound. What would you do?
Of course, give him no choice. He has to wear a hearing aid.
Great. Any different opinion?
No.
No.
Well,
So,
No.
I may disagree a little bit with Aziz. I had to do some kind of surgery.
I actually thought that
cases
Robert
like
would say that.
when we have this unique hearing ear, which is of course a very difficult decision. But I mean, it's a long-term discussion with the patient. I don't see a big issue in doing a basic tympanic membrane grafting, even in case of only hearing ear. That's another question if you have to do ossiculoplasty or if you have specifically to do a stapes surgery. So sometimes I do surgery on that case.
But Robert, I've seen, I'm sure you've seen also cases of myringoplasty ending with profound hearing loss. In fact, I've seen a case with bilateral myringoplasty ending with bilateral hearing, profound hearing loss that had to go into cochlear implant, which was a terrible thing, and with medical legal practice and all of that.
Oh, sure, but by chance I didn't cross this kind of situation myself, but of course it can happen for sure. That's all. This is why it's very important to discuss that with the patient.
I think for the sake of the target audience, I think we should state to them, no, for this patient, do not operate on them. Prof. Belal or Robert or Simon they can do that, but not for the junior or the intermediate level doctors. Now, tympanoplasty in children. This is a question that posed by so many in the group. Actually, is there any minimal age for tympanoplasty? Simon?
Theoretically, no. Practically, probably yes. I think the difficulties in very young children are more logistical than anything else. It's very difficult to clean the ear afterwards, and obviously.
So let me pose the question: what is the youngest that you have performed tympanoplasty on him, Simon?
I've done the youngest one I've done was 5 years old, but I prefer to wait a little bit more than that. They're just a bit more compliant. But it depends on the circumstances. If they're really having a lot of trouble with that ear, then I would operate on it before that, if it
right
can.
So
Dr. Ali,
yes,
for the junior we must differentiate for ear surgery. If we have a cholesteatoma, we have no age.
Sorry,
but if we have a safe ear, there is very good meta-analysis about the age in tympanoplasty. There was a relation between the success of tympanoplasty and the age, and the age of 10 year in tympanoplasty was the best in this meta-analysis study. So if we have a safe ear, it's better to postpone to 10-year old. I think according to the study, and we from our practice, because in child we have recurrence attack of otitis media, so the failure I think more than adult.
So Robert, what is the youngest that you have done tympanoplasty on him or her?
Just check on my database. It's 5-year-old, same as Simon.
You
But
just
again, it's an important question.
child comes to you with persistent ear discharge, and you look at the ear, you can see some polypoid middle ear mucosa, and the ear is persistently discharging. You keep giving them local medication, systemic medication. They come back to you with persistent discharge. You scan them, and there's no evidence. There is you cannot see any cholesteatoma matrix, and so it's not really cholesteatomatous disease. What would you do with these children? Would you just say, I'm not going to operate on them?
No, as I said before, I always try to dry out the ear first if I can, but if it doesn't work, then we have to do surgery at one point. So, and I have had to do it in some cases, and by chance it worked. I mean, the success rate is about the same. So it's very strange. So the only way to stop the disease sometimes is to perform the operation.
I see. So, Prof. Belal, do you have any younger than 5?
I think the crucial thing about children is allergy. Usually those kids that come with bilateral discharging ears, they had middle ear effusions that were mistreated and then perforated their eardrums, and their noses are terrible. They have adenoids, they have sinusitis, chronic nasal allergy. So you have to keep on treating those and delay as much as possible their surgeries. If they do not have allergy and they have bilateral perforations which are dry, the problem is the hearing loss when they are entering the school. So the school age of 6 is the critical age where you have to provide some good hearing for these kids before sending them to school. So we operate on them usually between 5 and 6.
Right. Okay. Great.
What you're talking about, much younger, of course, if I just operated on a 1-year case with bilateral congenital atresia of the external canal. So some children you have to do them very early.
Right, great. So now we'll come to the ossiculoplasty bit. I think the determinants of the outcome of ossiculoplasty is quite a big list, as you can see there. But we know that the in ossiculoplasty, if you keep the tension and alignment, these are important factors to maximize the hearing gain in ossiculoplasty. I think that question is for Robert Vincent. Is in case of absent stapes superstructure, apart from TOB, what would you do? And how would you counsel your patients? So essentially, there's no stapes superstructure. What we do here in Egypt, in many parts of the world, is actually do TOB. Do you do it differently? I know you have special techniques, Robert, about these things. Do you do them differently?
Yeah. Well, I as you know, I always do TORP, total reconstruction, also despite the presence of stapedial arch, when the stapes is present with silastic bending technique. But that's not the case here. Yes. So I would use a TORP. But the problem here would be to stabilize the prosthesis. And as you know, I've introduced this technique of malleus replacement prosthesis. So I would put the malleus replacement prosthesis first. I prefer to do that in 2 stages. So I will insert the malleus replacement prosthesis first, wait 6 months, and then go back for the second stage and put a TORP from the new malleus to the stapes full plate, because the presence of the malleus prosthesis will increase the chance of prosthesis stability. In that case, if you don't put something to stabilize the prosthesis, the success rate is, if you go to literature, and that's what I had before, is no more than 30% of success rate. So it's very, very low. So I would use this kind of technique now.
Right. So you would not use the old-fashioned, as in TOP with a cartilage on the tympanic membrane, as we do sometimes.
Yeah, but the problem is that if you put cartilage, it's because you want to stabilize the prosthesis. But how do you stabilize the cartilage itself? That's always the same problem. It's not stable. There's a great risk.
Do you have any experience with bone cement in osteoculoplasty?
Not myself.
Right. Anyone else has an experience with bone cement?
We have in Alexandria extensive experience with bone cements, especially in the incudostapedial disruptions. I think it's a very useful in this particular situation where you put a drop of cement. And even we have used bone cement now to stabilize the stapedectomy prosthesis over the long process of the incus, because we thought that the long-term necrosis of the long process post stapedectomy occurs because of the excessive movement of the. So we crimp and then put a drop of bone cement, but in osteoculoplasty, it is very useful, really, in this situation.
Well, I think using bone cement and stapes, we've published this in Otology and Neurotology 2 years ago, actually, is very good. But the main problem with it is that if you had to revise your surgery, then everything is amalgamated there, Prof. Belal, isn't it?
Well, I don't have revision stapedectomies. I don't know about you.
Fantastic.
Dr. Ali?
Yes.
I think the problem of stability of prosthesis and loss of supra-stable structure, we can use cartilage shoe, a piece of cartilage perforated, and pass the prosthesis from it. It will make more stability for the prosthesis. I tried it in many cases and work good.
Yes, but the issue with this side is that you're going to pass the prosthesis through the hole in the cartilage. How about the rim of the cartilage itself? It needs to be fixed. How would you fix the rim of the cartilage?
No, I don't fix it. Just gel foam around this part of cartilage. I think it will work good.
Right. Great. So now,
Ali, can I add something about staging? If you're doing osteoculoplasty and you are grafting the eardrum until it heals, it is unstable, and the hearing results using the prosthesis in the first stage are not usually very good. So I think if you stage and come back 6 months later to put a torp or a titanium or whatever you're going to use, I think you're going to have more stable situation where you get better hearing results.
I do agree.
So staging is a good idea also.
I do agree totally.
Staging for total replacements, I think, is important. I'm not quite so sure it's that important for the partials. Because the partials are much more stable, and you can usually get a good result with that. With the torps, I mean, I use the Kurt system, and they have a very nice Omega shoe which sits on the footplate of the stapes, and that does offer a degree of additional stability for the distal part of the prosthesis. It doesn't completely get around the issue, and the outcomes are still not as good as a partial replacement, but I do find that helps significantly.
Great. Let us go with this very common question by the audience, which is about eustachian tube dysfunction. The first question in relation to this topic is, how does the eustachian tube dysfunction affect the choice of my graft, fascia versus cartilage? Does it affect the choice of the graft? Saad?
Yes, first thing I think is another ear is a mirror of this is the ear. See the another ear, if retracted, mostly it eustachian tube dysfunction, and I go directly to cartilage precondylar graft.
Any similar experience with the others, or fascia can be okay with that?
I use cartilage for everything, so I don't have to make a decision. But
okay.
Feeling would be that if there is ongoing significant eustachian tube dysfunction, then cartilage would probably be preferable to fascia.
Fair enough. Now, the subsequent question to in the same topic is, in case of recurrent otitis media with effusion with numerous grommets insertion, would you tackle the problem by T-tube insertion, or would you actually go for a tuboplasty? I think that question for Simon, because you do tuboplasty, Simon. I know that.
Yeah, I mean, I discuss it with the patient, and if I'm honest, the best results I've had is if I use a grommet and then a tuboplasty at the same time, and that seems to extend the period that the ear is clear after the grommet comes out. But you know, that's not really got any significant evidence base. Yeah, so I'm not overly convinced that balloon eustachian tuboplasty is a fantastic intervention for patients.
Right. Okay. So probably the last question in this panel is about the experience with the subannular T-tube insertion. Anyone has experience in this of the respectable panelists?
Yeah, I've used it a few times and I think it's great. The only problem is the T-tube gets a bit crusty and you have to clean it fairly regularly. But if you've got somebody with a chronic middle ear problem and you've had to repair the tympanic membrane and you don't want to put a hole in the drum, an extraannular T-tube is quite a good option for them.
So the subannular one.
Yeah.
Great. Any more experience with this, Prof. Belal, Robert, Saad?
No. I think in recurrence otitis media with effusion with very activatic or syndrome, I think T-tube or any intervention will end with perforation of the drum. So I think in this case, cortical mastectomy with cartilage tympanoplasty, I think it will be one of solution of this situation.
Right.
Anyone agree with me in this concept?
And I actually all disagree with you, Saad, because they don't like cortical mastectomy, and I know that when you were off the stage. Anyway, we've come to the end of our panel discussion. I would like to thank you immensely, all of you, for your contribution, particularly our sincere friends from Europe, Vincent and Simon LIoyd. And equally important is to thank our dear Professor Aziz Belal and my colleague Aziz. So thank you very much indeed for your time. I totally appreciate your help, and I hope this is useful to the target audience in this platform. And thank you so much again, and have a good night.
Thank you, Ali.
Thank you very much. Bye-bye.
Bye-bye.
I'm happy, Ali, that we had similar opinions in France, Britain, and Egypt. We did not.
It's because as this, it's just because we are very polite. It's because we are very polite. So I'm happy to see Saad. How are you, Saad? Nice to see you.
Nice to see you after 10 years.
But I hope
thank you for your
thank you.
And I hope
Ali, I hope that you would touch on the future of laryngoplasty. Robert, do you think that the 3D engineering will affect our techniques in the future?
Actually, this question was not put to me by the audience. That's why I'm just giving you the question by the target group.
Well,
essentially. So.
I don't know. Really, I'm not sure about that. I still think that it's better to use the human tissue if possible. I think so.
Great. So I hope you are holding up okay in the UK and France in this COVID-19 issue.
Yeah, you too. Thanks very much again.
Thank you very much.
Bye-bye.
Thank you.
Bye-bye.
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 Thank you.